Right, so hemorrhagic CVA. So this is where you have a interruption of blood supply to your brain, which is the definition of a stroke, right? But it's due to a hemorrhage, right? We do call it a brain bleed, and pretty much any brain bleed we kind of treat like a stroke, even though the mechanism of injury might not be a CVA. It's still the same kind of thing. It's just like we talk about the complications acutely and chronically of immobility and dysphagia and fall risk. Those are all the same no matter how you injure your brain. But either way, it's the deadliest stroke, right? About 30 to 60% mortality, which is ridiculous, right? Like we have a patient going to open heart surgery today, and they won't take that patient if the risk is more than 3%, right? When we calculate the risk score and it's more than 3%, won't take them. That's way too high of mortality. But a disease process that causes 60% mortality, that's very, very high. 6 in 10 patients that get it die, right? So luckily it's only 13% of all of our CVAs. The other 87% is ischemic in gray there, right? On a hemorrhage, yes, it looks red if you open up the cranium, but it's going to look like what on CT scan? It's going to look white on CT scans. We've got all these different hemorrhage varieties. We have intraparenchymal hemorrhage. We have intraventricular, which can extend actually into the intraventricular space. I thought I had a spot for intraventricular hemorrhage, but those can definitely spread. So this little hemorrhage right here can spread right into that ventricular system right next to it, right? It's like a thalamic bleed right there, extending to the third ventricles. And then what else do we have? So these bleeds can be two varieties, right? So two vessels can get interrupted. We can just get a vessel that's within the brain, right? So it's anywhere within the brain. So you got one right here, you got one right there, you got maybe one on the side, but it's basically within the cerebrum, right? Or the deep nuclei of the cerebrum. So your basal ganglia, your thalamus, pons even, so and a cerebellar bleed, these are all possible, right? These are all yes, they're intracerebral. They're within the cerebrum itself, and they're within any structure within it, really, but those are the most common pieces. And we have a slide dedicated to that as well, right? So basal ganglia, thalamus, brainstem, right? Hypertension is number one reason for that. It just bursts through the vessel, right? So just as we looked at autoregulation with ICP, your brain can start reducing the blood flow to its brain if the pressure gets too high. It's like, whoa, 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 it's way too high. And then after a point, the pressure is just going to overcome the ability of the brain to vasoconstrict, right? It overcomes its strength. So it then will just burst through the vessel. Okay, and burst the vessels, and that can be due to chronic hypertension, hypertensive crisis of some sort, or it can be due to cocaine, meth, decongestants, which can contain phenylephrine or neosynephrine, right? So imagine you're just taking vasopressors. So that can also cause a rise in blood pressure and then burst through the vessel, causing a bleed of some sort, right? So not ischemia, we're talking about bleeds now, right? And what else can cause a intracerebral hemorrhage, where it's just within the cerebrum, because the other option is outside the cerebrum in the subarachnoid spaces. We can have a large ischemic stroke, right? So we have a huge ischemic stroke, we mentioned, can have a hemorrhagic conversion. We have a huge area of the brain involved, right? So we have a huge brain involved, and it can then, it can cause a cerebral edema, weakened cell membranes, and then therefore they can then, be susceptible to not rupturing, but susceptible to infiltration of CSF, and it can disrupt the membranes and cause bleeding to occur, right, as it disrupts the vessels as well. Right, so it's a hemorrhagic conversion from a large ischemic stroke. So hypertension causes ischemic strokes. They cause those lacunar infarcts. They also destroy the vessels on the way up and make it so the atheromas can lay hold and narrow the blood supply for ischemia. But also they can just straight up burst through the blood vessels, right? And cause, going back a step, they cause ischemic strokes, and then that can if they're large enough, can cause a hemorrhagic conversion. All right, and cerebral amyloid angiopathy, what the heck is that? That's just what happens with Alzheimer's disease. So Alzheimer's disease, has all the complications of immobility and such, and it's a progressive disease. It's not reversible, and it can be slowed down by like 3 to 6 months with medications, but eventually it's going to cause a bedbound state of a person they don't know, right? Or if it doesn't do that, as the brain literally shrinks, it's going to start tearing away at the veins, usually towards the middle side there, those bridging veins that are there, and it can cause it ruptures the veins, it tears apart the veins. It's just like like with the hemorrhagic conversion, the infiltration of CSF. Here, the veins are being torn as the brain shrinks, and they then hemorrhage. They develop an intracerebral hemorrhage because of that, right? And then anticoagulants. Warfarin is notorious for causing intracerebral hemorrhages. It has a really high risk. I'm not sure what the percentage is, like 1 to 2%, which is significant, right? But those newer agents nowadays, the 10A inhibitors or dabigatran, other heparins and Lovenox and such, they have a much lower risk. But they still have a risk of hemorrhage, and we have to be alert to that. We always have to ask, are you taking anticoagulants? Because we have met things. It's like you can't say, oh, cool, right? But that means you have to have, we have reversal agents that we can give to someone who has anticoagulant use. We can give reversals to, hopefully slow down the bleed, right? And then we move in, switching gears to subarachnoid hemorrhages, right? About 25% of your intracerebral hemorrhages. So of this 13%, if you split it in quarters, 1/4 of that 13% is your subarachnoid hemorrhages. So they are relatively uncommon, but they are significant. They have a really high mortality. I think it's coming up on the next slide with the aneurysms, right? It's like a 50% don't even make it to the hospital, right? So the other 50% are going to be debilitated afterwards. Okay, so we have non-traumatic, which means we have a aneurysm that's just rupturing, right, due to hypertension. So notice hypertension is in both spots. We got hypertension up there, we got hypertension down here, right? A little different mechanism, but basically, well, not really. It's busting through an aneurysm that it's been growing over time. Whereas like parenchymal hemorrhages, they just kind of rupture one day. Whereas the aneurysm's been growing until it pops, right? It weakens the wall, and it keeps weakening it and keeps weakening it, and that will then eventually rupture, right? So we'll talk about the symptoms and such with those, but again, we got drugs and stimulants that can cause that. ETOH itself vasoconstricts. That makes sense. That's going to worsen someone's hypertension. And postmenopausal females have the same risk factors as postmenopausal men or men, right? So they have the same risk factors after that point. They don't have the protective estrogen after that point, so they also have hypertensive risk, right? And then it's quite rare, but you can have what are called AVMs, arteriovenous malformations. That's where you don't form capillaries, right? They are in certain spots. They can be in the stomach, causing GI bleeds. They can be elsewhere in the body, but they can also be in the brain, right? So you don't have a capillary mechanism, right? Your capillaries kind of slow down the blood supply from 120, 140, 160, all the way down to a pressure about 5 to 10, right? So it's an amazing system that lowers your pressure dramatically, right? And your venous system is only capable of a CVP of what? Maybe 18 at the most, right? 20, 22. They're really fluid overloaded. So you imagine now you have 140 points of pressure just going straight into that area right there, and that's going to bust through those vessels at some point, right? So AVMs are another reason for a hemorrhagic stroke, right? Going from a high pressure to low pressure system. It just busts through those venous or those abnormal vessels. All right, and then we have traumatic subarachnoid hemorrhages, and we'll talk about those more with TBIs and trauma. But you can get hit in the head, and you can you can get a shearing or a damage to your vessels that are feeding your brain, right? So you have the circular Willis right there, right? Let's highlight that a little better. We got our circular Willis at the base of the brain right there, and if that ruptures in any fashion, that's going to cause a subarachnoid hemorrhage, right? Because if you look at how this sits inside the cranium there, all that blood, here's our circular Willis right next to it right there, all that blood's going to start filling up this area right here, right? It's all going to start filling up as that circular Willis ruptures. And that circular Willis is the first stop for blood pressure, so that's the most common spot for a aneurysm to begin with. And for traumas, that can also be where we can have rupture. Traumas can cause any kind of bleed. They can cause intraparenchymal, intraventricular, subarachnoid, subdural, epidural. They can cause contusions, contre coup. They can cause all these different injuries, right? So we're going to be layering them on until we talk about TBI at the end, because that encompasses everything we've been talking about so far, right? So we're going to learn each one kind of in a stepwise fashion. All right, so we got a little aneurysm right there. It's a common, one of our less common reasons for a hemorrhagic stroke, but it is an interruption in blood supply to the brain, right? If I lost blood supply just right here, I've got a little aneurysm there, I think, but your little aneurysm ruptures, So yeah, we zoomed in a little bit, right? We zoomed in and we ruptured the circle Willis right there. We're definitely going to have an interruption in blood supply to our brain. And it's going to bleed and bleed and bleed. And obviously we don't want the blood pressure to be too high after that. We want to get the blood pressure down, right? The blood pressure will go up because your body will try to compensate. It's like, where's my blood pressure at? I'm going to start vasodilating. That's not going to help ICP, but it's going to start vasodilating, and it's going to allow more pressure into the brain so that it can perfuse the areas that are not getting blood flow. Like this area right here is not getting blood flow, so it's going to crank up the blood pressure to 11 to get flow to that area. And we're going to say, calmate, it's okay, right? We're going to go ahead and give you nicardipine. We're going to give you some PRN pushes. We're going to slow down your blood pressure because we know with the increasing blood pressure, that's going to just make it ooze more. Okay, so we got subarachnoid hemorrhages, intracerebral hemorrhages, and I often mistake ICH for intracranial hemorrhages. I just think of intracranial hemorrhages, anything that hemorrhages inside the brain, right? So, epidural, subdural, all those things, but technically, yes, intracerebral is just the cerebrum itself. And then, which would include intraparenchymal, which means parenchymal means the working part of the brain, the gray matter or white matter. Which one is it? Gray matter, right? So your gray matter has an infiltration of blood, right? So that's an intraparenchymal hemorrhage. Okay, so we have all these different reasons we just talked about that lead to permanent deficits that hopefully we can maybe recover, but really there's not a lot we can do for intracerebral hemorrhages. Some things we can do, like aneurysms, there's certain strategies we can do, right? But like epidural hematomas, when we talk about traumas, we got to just evacuate it. You can't evacuate a subarachnoid hemorrhage unless it looks like a big, huge clot, right? Intraparenchymal hemorrhage, you can't just scoop out that part of the brain and say, okay, we're going to take out your thalamus now, all right? That's not something we can do. So it's really just, kind of thoughts and prayers, but there's some things we can do to fix the whole situation, right? So that's what we're going to talk about next as far as the different things we can do to try to fix it and avoid, secondary injury, which we talked about many times, right? Secondary injury with low oxygen states, right? Because low oxygen state in the first place is what caused this, worsening cerebral edema that will develop, and we got to stop that at some point. Okay, we got to stop the, this process of low oxygen states, low glucose states, low blood pressure states. We don't want to get the blood pressure too low, but we want to make sure all the numbers are normal, right? Otherwise, it can develop more chronic complications. Okay.
Morning, and thank you for coming to the activities room. My band is called School Nurse. Here's a little song I wrote about a patient of mine.
Aw, me?
Who was non-compliant with his meds.
Oh, crap.
25 days he stopped taking his pills. Metropolol in the Synapryl. Here's what's weird.
I'm old, I forgot.
His hypertension was not cured.
But it wasn't high anymore.
Realize quickly when you got a headache that perhaps he'd made a big old mistake. It's not a joke. Harry had a massive stroke.
Hemorrhagic.
Harry, come on, stand up and raise your hand.
I'm trying.
Sorry, Harry. Sometimes when my patients won't learn that their non-compliance will guarantee a return and will pave a road straight to their grave.
Well, that's harsh.
Okay. So non-traumatic subarachnoid hemorrhages. So these are ones that are due to an aneurysm that's rupturing. There are traumatic ones where it's from trauma. This is non-traumatic, where there wasn't any kind of mechanism of injury. It was just that their blood pressure was high enough to cause a aneurysm to start forming, right? So aneurysms start forming. Here's a circle of Willis, right? And they start forming and forming, and they start growing, and then they can then eventually rupture, right? So we're trying, hopefully we can catch it before then and find it, right? Sometimes they have what's called a sentinel headache, where they have this headache for months and they get a scan and they say, oh shoot, you got an aneurysm, right? And we can hopefully fix that. But unfortunately, that's not the most common presentation. The most common presentation is the worst headache of my life, right? It's a thunderclap headache. They'll describe it literally as thunderclapping, right? Even in different languages. They go, oh yeah, it sounds like thunder, right? So, and then I had this huge headache, the worst of my life, right? So this is because this was, it literally popped, right? So we have our aneurysm growing and growing and growing, and then it bursts through that saccule, and it will then start hemorrhaging into the space around it, right? That space is the CSF, and what's that space called? Called the subarachnoid space, right? Remember, all that CSF eventually gets reabsorbed into the venous sinuses. And that's, spoiler alert, that's one of the complications, is that we can get hydrocephalus from this blood that will then start occluding those little subarachnoid villi, right? So there's outpouch in the vessels in weakened spots, right? Usually the bifurcations and with these communicating arteries. So we have our ACA up there, and we have the anterior communicating artery, which is between the two ACAs. We have the, the middle cerebral arteries on both sides, right? We're looking at the bottom of the brain right now, so the MCA on both sides right there. And at the bottom there, we look in there, we can see we have some, little communicating arteries that are at risk for aneurysms, okay? Anterior circulation is the most common, because remember our posterior circulation is it's just kind of back up, and it's very important because it serves the brainstem, but it is it's not as high pressure system as the arterial system on the front half, right? Remember off the carotids is where the circle Willis gets fed by, right? Circle Willis gets fed by the carotids, left and right, and then the posterior circulation was from your vertebral arteries, right? And those have been, the pressures get reduced just a little bit. All right, 10 to 15%, so it wasn't 50%, but about almost 20% die prior to even arriving to the emergency room, and then once they get in the ER, it's about 50% mortality, which is extremely high, that we have to try to identify and then try to fix if we can, right? And then afterwards, about 50% have permanent deficits. Even if they made it and they survived, 50% will have those permanent deficits of chronic immobility, chronic deficits that they may not recover from. Okay, so all this irritation from all this blood down here is not just going to cause, just be annoying and cause a headache because of the increase in intracranial pressure. Blood itself is very, very irritating. So it's going to irritate everything around it. It's going to start irritating the brain and the meninges that cover the brain. You're going to start getting like meningitis symptoms. No fever, but you're going to start getting nuchal rigidity and, of course, headache, right? And then, of course, the meninges are, your optic nerve and has to go through your meninges, so you start getting photophobia as well, okay, which is classic for a meningitis patient, right? And also we have what else? These blood vessels are very, very susceptible to irritation, and that blood is going to start irritating the blood vessels that are there, and they're going to start irritating to the point where it vasospasms, right? So cerebral vasospasm is a significant side effect, and it's not just like, oh, too bad you have this waxing and waning focal deficit where that blood irritated, right? Let's say the blood irritated our middle cerebral artery right there. Then you're going to have an MCA stroke all of a sudden, right? And then it goes away. It's waxing and waning. It's wax on, right, and then wax off. Okay, so it's going in and out. They have this deficit, and it can be a deficit that is significant enough to cause a high mortality. So it's not something just like, oh, you'll get through this. It's something that requires intervention. Okay, requires us to give medications to fix it, right? And what's the medication? Basically any kind of vasospasm throughout the whole body, right? Whether it be a radial artery harvest for a cabbage or it be a spasming of like Prince Metal's angina of the heart, you give which medication? You give calcium channel blockers, right? The dipines. So those guys you're going to give to stop the vasospasm from occurring, and it's this specific one works best in the brain. They compare the other ones, and it's nimodipine is the one that is going to be on top for your brain, right? It's going to be there to stop vasospasming. We give it prophylactically, usually for 21 to 30 days, and that will prevent vasospasm after an aneurysm. It most commonly happens about 4 to 14 days after, but we're still not going to chance it until now it happened, let's go ahead and give the medication now, right? Like some neuro diseases, like you don't give seizure medications until they have a seizure, right? But with this one, you're going to give nimodipine immediately, right, as part of the package deal if someone has a subarachnoid hemorrhage of any sort, okay, traumatic as well. And then we have rebleeding is another complication that can happen. As we can hopefully, maybe it stops spontaneously, or we have to do an intervention, but it can rebleed spontaneously. With all this irritation that's happening in the brain here, we're going to start stimulating the SNS, right? So not only are we stimulating the optic nerve to cause photophobia, we're also going to cause the SNS to be firing off at ridiculous rates, and it's going to start causing a SNS storm through the whole body, causing tachycardia, etc. But it's also going to work on the heart to the point where it causes stress cardiomyopathy, which is also known as broken heart syndrome, right? When a loved one dies, you have such stress in your body, your heart literally breaks. And it's called Takotsubo cardiomyopathy, right? Where it looks like an octopus in Japan. It's like, okay, cool. All right, so that's called a Takotsubo cardiomyopathy, or you can literally see an echo. It looks like an octopus, right? Little, you can imagine like 8 feet there, and there's a little smiley face octopus. The left ventricle is all dilated out at the bottom there. Okay, so can we prevent that? No, we can control their blood pressure, but that's something to be aware of, that they have, they could get LV failure, pulmonary edema, right? The Takotsubo. I spell it out on the next slide. All right, so Takotsubo cardiomyopathy. And they get this unique EKG finding that you only find with intracranial hemorrhages, and especially with subarachnoid hemorrhages, which is this cerebral T waves, right? If T waves are inverted, it's a problem. When T waves are like super, super deep like that, that's usually a brain situation. That's a brain problem that you'll be looking for. So it's time to get a CT scan if someone's EKG looks like that, right? Okay, so, and of course, with all this irritation, all this blood that's pooling, it can start pushing the brain aside, and it can get herniating symptoms. You get increasing ICP, and it can start herniating on different structures, causing all the different syndromes we talked about before, where it can go left to right, a subfalcine herniation. It can go downward through the tentorium, causing a uncal herniation or central herniation. All these are things that can result from a subarachnoid hemorrhage, whether it be traumatic or non-traumatic, really. All right, but as far as an aneurysm that is big, you can maybe fix it, right? So we have a aneurysm here that we want to try to stop from hemorrhaging, or stop from bursting, or if it has hemorrhaged, we can then maybe stop it from hemorrhaging more, right? So that is by 2 methods. That's with coiling or with clipping, right? And clipping is where you literally peel back the skull. You open the skull, you peel back the brain, and say, oh, there you are, there's your circle Willis, and you go in there and you clip it, right? And it's usually with people that have tortuous vessels, right? Where they have vessels that they really can't get to if they were to go endovascularly, right? When you go endovascularly, you take your catheter from the femoral artery and you run it all the way up. It's going to go up the carotids, really, right there. And it's going to then go up to the vessel, and it's going to start to coil that piece right there. And what does coiling mean? It's just the deposition of onyx, right? So you got onyx that's being deposited there. They might even taste like rocks afterwards. Like, what's that dirt taste? That's the onyx that we just coiled inside your brain. Okay, so they place those coiling coils inside the brain, and it's going to clot off, and therefore now you have a hardened structure that is going to not hopefully burst after a while, right? So that's the idea behind coiling. And you can only do that if your catheter can actually reach inside, right? So they have to have a wide neck, not a fat neck, a wide neck of the aneurysm, right? So that wide neck allows them to get in there and coil it, fill it up with the coiling material, the onyx, and they're then able to clot off the vessel, not the vessel, but the ruptured, the outpouching of the vessel, and therefore it can be hopefully fixed, right? And the other option, of course, we said was doing a clipping, where you peel back the whole skull and whole brain, and you go in there and you clip it. Obviously, that's a lot more invasive. Okay. After you've done these procedures, you do what's called Triple H therapy, not for hemorrhoids, but for aneurysms. And these are a little bit extreme. They kind of get out of control sometimes with our neurologists, neurosurgeons. They like to, let's get the sodium 165, or let's make the patient 32 degrees Celsius. Let's go ahead and do, X, Y, and Z. They go a little bit hard. All right. So, we take it with a grain of salt. We do know that we want to fill the vessels, right? We don't want that vessel to start spasming from all this blood here. We don't want the vessel to spasm. So if we keep the vessel open, that should prevent it from spasming, right? So that's the idea behind hypertension. We keep the blood pressure about 140 to 160. We don't want it too low, because then it's very, very ripe for being squeezed, right? So hypertension is something we can maintain, right? So blood pressure about 140 to 160, around 150 there. Hypervolemia, they used to say go ahead and crank the CVP up to 12 or 14 even, but that we don't really follow CVP for volume resuscitation. But you definitely don't want their volume status to be on the low side. We can use what's called POCUS, right, point of care ultrasound, to see how much fluid volume there is sometimes. We can see how responsive they are. We can look at their intake and outputs to make sure they're not getting negative. And there's hemodilution, all right, by the same technique like with sickle cell disease, how you want to improve perfusion of vessels and of end organs. You want to make sure the vessels are not, or the blood is not thick like honey, right? You want, or molasses. You want to make sure that it's flowing nicely and it has good adequate flow. So fluids will do that, all right? So whether it be normal saline or LR, that will allow our good enough perfusion through there, right? So Triple H therapy is kind of with a grain of salt nowadays, but we definitely are going to be monitoring to make sure there's no vasospasm. They do like frequent ultrasounds to make sure there's no vasospasm occurring, or looking at a risk of vasospasm. They can do this to assess risk factors, and also maybe up titrate doses, increase blood pressures, or increase volume if need be. All right, so again, non-traumatic and traumatic, right? So we got our hemorrhage down here. Our hemorrhage will be very irritating to the meninges, right? Causing meningismus. So that's just our meninges that are being irritated. So we got different layers going on here. We have the pia mater, the dura mater. We have all these different things that can get irritated, right? And we get nuchal rigidity, we get photophobia, and yes, you get some headache as well, right? Are they gonna have a fever? No, because this isn't like proper meningitis. When you have an infection of your meninges, that's going to definitely start causing fevers and the same meningeal symptoms, meningeal irritation. All right, what else happens is we get vasospasm occurring, right? So we just talked about, right? All this blood vasospasms the artery, and if it's your MCA, you get a waxing and waning MCA strokes. Or if it's your ACA, the ACA symptoms will appear. And of course, they'll get altered as well with this. Okay, so we got a cerebral vasospasm, we got cerebral edema, of course, and meningismus due to inflammation. That sympathetic cascade we talked about with these. What kind of T waves are these? These are called cerebral T waves. Yep. All right. All that irritation is going to cause an SNS storm, and it can cause a cardiomyopathy, LV failure, pulmonary edema. Right. Like we had a patient that was in their 40s, and this young girl had she doesn't have any heart failure, right? But we know on CT scan she has a huge bleed. So, and she has this prominent pulmonary edema. She's coughing up pink frothy sputum. She had required intubation, and all this is filling up her Ballard, her suction device. And he's like, well, what's causing it? So we asked, can we get a CT angio to see if she has a ruptured aneurysm? Sure enough, she did. And we have to get her to a facility that can do the clipping or coiling to stop the progression of their aneurysm. Okay, so CT scan, again, will reveal a subarachnoid hemorrhage. It's with contrast, of course, but it's about 95% sensitive, but sometimes it doesn't, and it might be a smaller bleed, and we have to do an LP, and we get a result that's called xanthochromia, and xantho is just Greek for yellow, right? So yellow chromia, yellow color. So CSF, that is a yellow color. So if it turns yellow, that's pathognomonic. There's like really no other reason why your CSF is yellow besides subarachnoid hemorrhages. Okay, and why is it yellow? Well, RBCs get neutralized in the bloodstream. They also get neutralized in the CSF, right? The heme and the globulin particles, they get bound to and formed into bilirubin, right? And it has a yellow color to it, right? The haptoglobin, all the other fun stuff. So we have this increase in RBCs that we can detect when we test the sample, but also we have this yellow color. Okay, and just a note, when you're looking at LPs and CSF samples, they say there's traumatic and non-traumatic types. And a traumatic type is where they poke and they hit an artery and it starts to ooze around the area, and it goes down in RBC count with each canister. We usually get 3 samples, right, of CSF. But going down with each sample, that means that it was traumatic, right? When you're getting a true CSF sample and you measure it 3 times, the RBC count shouldn't change, right? Neither should the glucose count or the your cell counts as well. Okay, so CT angio is our definitive way to figure out if they have an aneurysm or not, right? And before we do LPs, we got to make sure the ICP is not elevated as well. So they have signs of increase in ICP. We don't want to do an LP because otherwise all the brain tissue will then go out the little small hole you created in the spine. Okay, so our CT findings are of a subarachnoid hemorrhage, right? A CTA is going to definitely find that aneurysm before it bursts, But once it does burst, right, once you got this aneurysm here bursting, we're going to start getting a subarachnoid hemorrhage that's starting to fill up the base of the brain here, right? So we have these little cisterns and crevices that could get filled up, the little sulci here. See all these different areas here that could get filled up, right? We got our superior cistern, we got our chiasmatic cistern, we got our Ponti cistern, all these areas where the CSF flows. If my circular Willis right here ruptures, it's going to start filling these areas right there, right? So we're going to be able to see that on a CT scan. We're going to see it filling these cisterns, right? So if you see a normal CT scan, they're empty, right? They are black, or dark gray. They're not filled up with blood. But here you see there's blood filled up right here, right? There's blood filled up right there in the base of the skull, and that's starting to look like a what? Like not a Death Star. I got really excited, and they say, "Oh, you're going to see a star like a Death Star on the CT scan." I was like, "Where? I don't see it." Right? So it's a star that equals death because we know there's 50% mortality. So it's a star-like appearance. You might not get all 5 lobes of the star, and here's a nice 5 stars right there. 5-star Yelp review. This one doesn't have all 5 stars, would not eat there, would not recommend, right? That is going to be, but it's still a severe subarachnoid hemorrhage. Obviously, the one with all 5 points is going to be much more severe than when it has 4 points or 2 points, right? But you can see it's filling up different parts of the cisterns, the different valleys and bases of the skull, right? Just filling up from the bottom up, right? And if you notice, people with Alzheimer's disease, they shrink their brain. Their brain literally shrinks over time, right? Compared to a normal brain right here. Here's our normal one, and here's our Alzheimer's one. You can see that everything's starting to shrink, and they're going to have more filling up of space. But also, just to point out, with our like our subdural hematomas or our hemorrhagic strokes, that's the reason, because it's pulling the vessels with it, right? All the vessels are being pulled with it as it's being shrunk, and you're at risk for bleeding. All right, that's cerebral amyloid angiopathy, right, is another significant risk factor for intracerebral hemorrhage. All right, going back to the Death Star. So we have our Death Star that is bad, right? And how do we fix it? There's nothing you can really do. You can't just take out a portion of the Death Star. You can't blow it up. You have to observe, right? There's nothing to do with this. We're going to prevent vasospasm. I shouldn't say there's nothing to do. We're going to prevent vasospasm, right? And if the aneurysm is oozing, aneurysm is something we can intervene upon. We're going to take them to interventional neurology to get that coiled, if it's coilable, or we have to, crack open the skull and clip it. Okay, so they can rebleed, as we mentioned. That's a common complication. And we have to assess for hydrocephalus, right? So we talked about hydrocephalus is when the brain starts swelling and swelling and swelling because of there's too much CSF being produced in the choroid plexus and it can't flow through the brain, or the little pieces up here, right, our little subarachnoid villi that are sticking into the subarachnoid space where our bleed is, are getting clotted off or clogged, right? They get clogged with infection like cocci and such, but we're talking about being clotted off with a subarachnoid hemorrhage. Okay, so we have a communicating hydrocephalus, right? So it's still communicating from the intraventricular spaces downward, right, into those subarachnoid spaces. But it's still communicating all the way through. So that's a communicating hydrocephalus. Non-communicating would be if you had like an intraventricular hemorrhage, right? Or you had a mass that's interfering with the normal pathways of CSF through the brain. Okay, so what else? So we got subarachnoid hemorrhages here. We'll be talking about some intraventricular hemorrhages right there. So it's an IVH, right? We have some like a brainstem hemorrhage. We got a intraparenchymal hemorrhage over here. There's my Death Star right there with a subarachnoid hemorrhage, right? And subarachnoid hemorrhages cause an SNS storm and cause a really severe tachypnea, tachycardia, causes a neurogenic pulmonary edema, causes heart failure. Okay, so these are all our complications and kind of our whole subarachnoid hemorrhage picture.